Assalamu alaikum students. This is the second part of myocardial infarction, and these are our learning outcomes. We have discussed about the definition of myocardial infarction, etiology, its types, its pathophysiology, many clinical manifestations, complications, and now we will discuss what happens in infarcted area, describe causes of death after acute MI, elaborate stages of recovery after acute MI, discuss diagnostic tools for MI, and discuss treatment options. So these are our learning outcomes. What happens in infarcted area? Soon after the onset of infarction, collateral blood begins to seep into the infarcted area, and progressive dilation of local blood vessels. And as a result of these two effects, there is the overfilling of infarcted area with stagnant blood, and the muscle fibers use last vestiges of oxygen in the blood, causing hemoglobin to become totally deoxygenated. So the last amount of oxygen is utilized, and there then remain deoxygenated blood. And due to this deoxygenated blood, the color of infarct becomes bluish brown, and the blood vessels appear to be engorged despite lack of blood flow. And in later stages, the vessel walls become highly permeable, thus fluid leaks, and the local muscle tissue becomes edematous, so that the cardiac muscle swells. So in later stages, there is swelling of the cardiac muscles due to leakage of fluid from the vessel walls. And finally, within a few hours of almost no blood supply, and the cardiac muscle cell die. So these are the few events that occur after infarct. And subendocardial infarction, the subendocardial muscles become infarcted even when there is no evidence of infarction in the outer surface of the muscle. And what is the reason of subendocardial infarction? Why it occurs first? And because it is the underlying muscle of the heart, and there is a difficulty in reaching the blood to that area, and when the heart contracts, there is pressure on the blood vessels, so there is extra difficulty in obtaining adequate blood flow, because blood vessels in it are intensely compressed by contraction of heart. So it is the internal area, and it requires blood at the last stage, firstly outer side of the heart, then inner side of the heart. So when the infarction occurs, the inner side of the heart, that is far from the blood supply, their infarction occurs on priority basis. Their infarction occurs firstly. So because this area is away from the blood supply, and this is on the inner side, so the signs of infarction can be seen at the subendocardial muscle, while there is no infarction, no evidence of infarction on the outer surface of the heart. And the causes of death after acute MI: decreased cardiac output, damming of blood, pooling of blood in pulmonary vessels causing pulmonary edema, fibrillation of the heart, and rupture of the heart. We will discuss these causes one by one. Number one, decreased cardiac output. When the heart becomes incapable of contracting with sufficient force due to no or reduced functioning of cardiac muscles, enough blood cannot pass to periphery, causing cardiac failure and death of peripheral tissues due to ischemia. This is called coronary shock, cardiogenic shock, cardiac shock, or low cardiac output failure. These are few names, because when the heart becomes weak, it cannot supply the blood to the periphery, and this results in shock. And this causes reduced blood supply to vital organs, especially kidney. Acute renal shutdown will occur, and when there is a reduced blood supply to brain, there is a neurogenic shock. These shocks are due to decreased cardiac output, and the decreased cardiac output is due to heart failure, because of cardiac failure, because there is myocardial infarction. So the heart can not work properly, incapable of contracting. And damming of blood in systemic and pulmonary circulation. When the heart is not pumping adequate blood forward, it begins to pool in systemic and pulmonary circulation. In right side, in case of right side of the heart, there is a systemic pooling, and in case of left heart failure, or when there is not proper functioning of left side of the heart, there is pulmonary edema. So both types of edema can occur, and this damming causes leakage of blood, leakage of fluid, leads to peripheral and pulmonary congestion or edema. So at both points, that is at the periphery in case of right heart failure, and in pulmonary edema in case of left heart failure. So both can occur. When the blood cannot go in forward direction, then there is pooling, or there is damming of blood in either systemic circulation or in pulmonary circulation. Fibrillation of the heart. Actually, the fibrillation is the circus movements of that is due to irritation of the heart, and in this the heart can vibrate at a far greater heart rate than normal. So the tendency to develop fibrillate is more in larger infarcts than a small one. And there are two most likely periods in which it occurs: during first 10 minutes after infarct occurs, and beginning of 1 hour or later. It may occur less likely many days after infarct. And factors for heart to fibrillate, these are acute loss of blood, ischemia of muscles, powerful sympathetic reflexes, and cardiac muscle weakness. So these are the few causes or few factors which results in the fibrillation, which results in the circus movements. We will discuss in the fourth lecture of cardiac arrhythmias. We have discussed in fourth lecture of cardiac arrhythmias about fibrillation and flutter. So rupture of the infarcted area. After a few days, dead muscle fibers begin to degenerate, heart walls become stretched very thin. So due to these two reasons, due to both of above, dead muscles bulges outward with each heart contraction, and this systolic stretch becomes greater and greater. Finally, the heart ruptures. After rupturing, pericardial cavity becomes filled with blood, leads to cardiac tamponade, compression of heart from outside by fluid. So this is very important, that when the dead heart muscles become degenerated and dead, and the heart walls become thin, and when due to the heart contractions, there is systolic stretch becomes greater and greater, and finally the heart ruptures. And due to rupturing of the heart, the pericardial cavity becomes filled with blood, and there is a pressure on the heart from outside by the fluid that is present in the pericardial cavity, and this condition is called cardiac tamponade, compression of heart from outside by fluid, and that fluid is present in the pericardial cavity, and this fluid is due to rupturing of the heart. So this cardiac tamponade is very important. We remember about cardiac tamponade. And the stages of recovery from acute MI: when area of ischemia is small or no death of cells, muscle often becomes non-functional temporarily because of inadequate nutrition. And when the area of ischemia is large, muscle fibers in the center of the area die rapidly within 1 hour, then extending circumferentially to non-functional area. extent of recovery depends on the area of ischemia. If the area of ischemia is small, then recovery will occur very soon. And if the area of ischemia is large, then it take time. And replacement of dead muscle with the scar tissue, much of non-functional area recovers due to development of collateral vessels supplying outer rim of infarcted area, and fibrous tissue develops in the infarct as ischemia stimulates fibroblast, thus promotes scar formation. And fibrous tissue has a property of dissolution and contraction, and it grows smaller over a period of a month. So due to two things, that is the development of collaterals and due to ischemia induced fibroblastogenesis and the development of fibrous tissue. So the development of fibrous tissue and collateral vessels will lead to replacement of dead muscle. Okay. Okay. Now we move towards how we can diagnose the myocardial infarction. So we have serum cardiac markers. Number one is creatinine and creatinine phosphokinase myocardial bound, CKMB, lactic dehydrogenase, and cardiac specific troponins. These three are the cardiac markers. And then ECG changes, ST segment elevation, T wave inversion, wide deep Q wave. You have seen in the previous slides these ECG changes. And these ECG changes can be also shown here. You can see here ST elevation, then R wave, then Q wave changes, and then Q wave wider, T wave inversion, ST normalized, T wave inverted, and Q wave persist, while ST and T wave are normal. So with the passage of time, the changes occur which are in front of you, which we have discussed in the previous slides as well. And then the other diagnostic tools are magnetic resonance imaging, angiography, positron emission tomography, PET scan, and chest x-ray. These are the diagnostic points for MI. And then treatment options, counseling, lifestyle modifications. Avoid lifestyle modifications include that is exercise and dietary control, and mainly there is the stress relief of stress, and exercise are included in lifestyle modifications. And then avoid smoking and alcohol intake, and then dietary restrictions, especially salt intake. Medically, thrombolytic agents, anticoagulants, antiplatelets, vasodilators like your nitroglycerin, nitrates. Vasodilators include nitrates. And then antihypertensive drugs, lipid-lowering drugs, which include statin group, lipid-lowering drugs. And then surgically percutaneous transluminal coronary angioplasty, and coronary artery bypass graft, and atherectomy. These three are the surgical changes, surgical treatment options. So counseling, lifestyle modifications, avoid smoking and alcohol intake, dietary restrictions, salt intake especially, medically thrombolytics, anticoagulants, antiplatelets agents, vasodilators, antihypertensives, lipid-lowering drugs, surgically percutaneous transluminal coronary angioplasty and coronary artery bypass graft, and atherectomy. These few are the pictures of percutaneous transluminal coronary angioplasty. There is the implantation of balloon and stent, and when you can see here in the second picture, in this picture the balloon is inflated, and when the balloon is inflated, there is expansion of stent, and when the stent is expanded, the narrowing or the of the vessel due to spasm or due to the plaque formation is relieved. There is also a stent placement. First picture, the stent is closed, and when the balloon is inflated, the stent is open. This is atherectomy, by which you can remove the thrombus. And the coronary artery bypass graft, the major treatment option, cabbage. You can see here there is a bypass from a coronary artery. From this coronary artery to here, this is the cabbage coronary artery bypass graft. And these are the overview of management of acute MI. This is very important, how you can manage the acute MI. Pre-hospital management, aspirin, call to the emergency department, and continuous cardiac monitoring. Consider pre-hospital 12-lead ECG and emergency department treatment. Intravenous success, continuous cardiac monitoring, 12-lead ECG, aspirin, oxygen, nitroglycerin, morphine, heparin as anticoagulant, beta blockers as an antihypertensive, and then reperfusion strategies. Primary percutaneous primary percutaneous coronary intervention versus fibrinolysis for STEMI, glycoproteins 2B or 3A